Good morning, good afternoon, good evening, friends. Depending upon which part of the world you are joining us from, this is Dr. Vijay Agarwal, President of CAHO, welcoming you to yet another episode of the International Webinar Series, which we hold on every first Tuesday at 5 p.m. Indian time. So it's indeed my proud privilege today to introduce you to the moderator of the day today is none other than Dr. Bishnu Panigrahi, my good old friend, that when we spend time in the Max Healthcare, and after that, you have gone places. He has been a great visionary, educator, author. He has been the CEO of the Kalinga Institute in Odisha, and after that, he is now the Group Medical Director of the Fortis Healthcare for medical strategy and operations. So Vishnu has a cardiac anesthetist by background, but I know for his passion for the quality improvement and his focus on quality is absolutely fantastic. So he was just the right person to kind of be the moderator on this session by Dr. Emmanuel. So without much ado, I'll request Dr. Bishnu Panigrahi to kindly introduce the topic as well as Dr. Emmanuel. Over to you, Dr. Bishnu.
Thank you, Vijay, for the kind introductions, and we go a long way back, and it was a pleasure working with you. We developed a nice hospital, which is a flagship in Delhi now. So it's always good to reflect back on that we built something together, and we can be proud that things have gone off well. And I'd like to introduce first Dr. Emmanuel. He's from Nigeria. He's a member of the ISQua also. He's a professional who has stranded all the aspects of healthcare, if you look at it, on planning, on quality. He's also a Six Sigma black belt. And there's no better speaker than him to take us through. And as Dr. Vijay rightly mentioned, on our monthly webinar series. And most important is what he's going to talk about is the quality improvement programs. So as we develop healthcare, some of the things that we are lacking, and Dr. Emmanuel, I don't know whether you have that in mind. I think the public health has been a major lacune across the world now. And this once in a century pandemic that hit us across the globe, it has shown us the mirror. I think so public health needs to be taken care in a much better way than what it has. Obviously, healthcare is another part of it, but the public health part, because I was going through your CV, there's a lot of work that you've done in public health. So while you speak, if you could sort of just educate us on what are the things that we need to look at as healthcare providers, because the audience has members from across the healthcare spectrum in India and from outside also. So it'll be a nice thing to take it forward. And without much ado, I think so I'd like to hand over to you, sir. And I also have some connection with the Nigeria, because the Hygia group was there, and we had association from Fortis Healthcare. We set up, had some O&Ms there, was involved in the Lagoon, that new hospital that came up in its commissioning. So I go back to some old days of Nigeria. It's a lovely city. It is the largest populated country of Africa, and it is they say that it's the country which is setting the pace in Africa and in the African continent. So there'll be a lot of learnings from you, sir, and I'd like to. We are eagerly waiting forward for that. And over to you, sir.
Thank you so very much, sir. I appreciate your kind words. And as I do that, I would just want to, first of all, appreciate CAHO for this opportunity to speak to you and speak with you and learn with you. And I would ask you to share with me your lovely music at the end of this presentation. That was very heartwarming and totally inspiring. So, as you have said, and greetings from Nigeria, it's important that we begin to look at the quality improvement programs, not just within hospitals or laboratories or diagnostic centers, but be able to spread that learning the philosophy that guides the work of improvement, the toolkits that we have access to in the space of improvement, and begin to use them in the public health space. That is very, very key if we're going to be able to harvest the learning that is possible and the results that are possible for us to harvest using the methodology, the frameworks, the philosophies, and toolkits that we have in the space of quality. And as we start, I would just want to say that at the end of this session, the expectation would be that participants would be able to apply the principles of quality improvement in the work that they do, regardless where that work is. And also, we will be able to share within our purview the complex quality management structures and be able to determine what kind of designs we can employ to improve the outcomes of the systems that we work in. We would also touch a little bit on quality improvement programs, the elements that make those, and not just for the sake of learning, but more importantly, the opportunity to act on the things that we're going to learn together today. And finally, but very importantly, would be able to either contribute to the creation of or actually create, if we are in the position of authority to do that, effective and efficient quality improvement programs in the work that we do. The definition that I have here. So when we talk about quality improvement programs, we can confuse that with quality improvement project, with tasks and activities, operations, things that we do within facilities or organizations or within the public health space in an effort to change some narrative. However, a quality improvement program involves systematic activities. So these are not random or randomized activities. These are systematic, methodical activities that we have taken the pains to organize in response to some performance gaps, and we are implementing them not for the sake of ticking check boxes, but primarily to monitor or assess, and most of the time to improve the quality of healthcare or the quality of health or the quality of the work that we're doing. So it has to be something that has been organized and structured. It has to be towards the end of monitoring or assessing or improving the quality of health or healthcare, as the case may be. So it's important that we put this definition at the back of our mind. But if we talk about quality improvement programs and we don't have a common understanding or an agreement on what quality even means, we may be doing counterproductive activities in the space where we find ourselves. So the first thing is that we want to define quality following the Institute of Medicine definition from 2001, that quality is seen as the degree to which health services or health products or health systems for individuals and populations increase the likelihood, right? So we know it's a complex adaptive system, very often unstable, evolving, dynamic, risk-prone, but we want to increase the likelihood of achieving the desired health outcomes. And these services, right, must be consistent with the current professional knowledge. So it's not something from the 18th century or the 19th century. It must be consistent with the current professional knowledge. So when we design services or outputs for individuals and populations that increase the likelihood of them achieving the desired health outcomes, we're talking about quality. Let's bring in the World Health Organization definition of quality of care. It also says that it's the extent to which the healthcare services, again, or the products or the activities we're doing, provided to individuals and patient populations, improve the desired health outcomes. In order to achieve this, WHO agrees with the Institute of Medicine that healthcare must have certain dimensions or certain elements, which we summarize as STEEP, S-T-E-E-P. And the STEEP basically stands for safe, the E, first E, effective, second one, efficient, equitable, and timely, and then person-centered. So these 6 dimensions, according to the Institute of Medicine, in agreement with WHO, describe to us what we see in healthcare delivery that helps us say that was quality or that healthcare was of high quality. These are the things we'll see. It's not very subjective in this respect, but you remember that every definition we've looked at places the individual or the populations in question at the center of all the decisions that we have to make and the design that we have to consider as we begin to pull health together. Now, quality improvement programs and the result that we get in quality improvement programs are not random results. They are very specifically designed. And in every quality improvement program that you would see that will produce the kind of results that you want to see, there are certain principles that such programs must adhere to or be compliant with. The top four, in my opinion, would be that, first of all, there has to be the setting and the meeting of relevant and significant standards. There has to be an agreement as to what the benchmark is. This is the bar, right? This is what the standard of quality is. There has to be that defined, and it has to be crystal clear to every stakeholder that is involved in this conversation. Now, having and knowing what the best standard is doesn't automatically translate into the results, right? There is a process, there are mechanisms, there are systems behind the systems that have to be put into work for you to be able to say that you're going to move the performance of your institution, your organization, or the public health space from where it is at to where you need it to be, right? And that process is what we say that is a journey. It's not an event, right? There may be certain events in the space, but it is a journey and a continuous journey at that. So you set the standard, the relevant and significant standards must be set, and then you have to build the right resource infrastructure. It takes certain thinking, it takes certain input for you to be able to convert the things you know are not right to the things that should be right. So those have to be properly considered. And here we've said patients and clients, but we're not only limiting these to the hospital space or the laboratory or diagnostic space, but even to public health as a whole, right? So set the standard, build in the resource and infrastructure informed by the standard you've set. Then we always chime this and we sing it like a chorus that quality is data-driven. And we cannot overemphasize that. I think it was Deming who joked about this, that in God we trust, every other person must bring data. We cannot overemphasize the need and the centrality of data in quality and quality improvement. So you must build an ability, the infrastructure and the process for your system to be able to collect and use robust, relevant, and quality data. And the final bit, which many people may not think is important, but is quite critical, is the fact that as an organization, as a country, as a unit, as a team who is interested in setting up a quality improvement program, it is important that you have at the back of your mind how you're going to submit yourself or your organization to a process of verification, right? So this is saying an external person or an external organization needs to come in, right, at regular intervals to help you look at your processes, look at your structures, your facilities and the outcomes, and provide some form of feedback so that they keep you on your toes. And that level of accountability, that system of accountability also goes back to help you to continually improve your system. All right, let's just talk about this quality management in a bit. And it was Joseph Duran who postulated or designed the quality management system to have three components: the quality planning, the quality control or quality assurance, and the quality improvement. And this picture here, so we say that the quality improvement part is one that some people are used to. Some other clients are also more used to the quality assurance bit, the accreditation, the audits, and all of that, right? But to understand that quality planning talks about those, we earlier spoke about processes, the policy, the governance, and the coordination, setting up the necessary environment for organizations to thrive, right? That thinking, that accountability, that governance is what quality planning. So they are the ones, the people responsible for quality planning will be the ones who would say, this is the direction we want to go. This is the strategic direction this organization needs to go. And these are the things that we're going to need to get there. So they set the direction, they provide the resources and all of those things. The quality assurance begins to talk about the guidelines, protocols, standards, performance review. But it's because you have those standards that you're able to say, oh, this was what we had set. But for whatever reasons, we're not hitting that target. So there is a gap between what we should be doing and what we actually are doing. In the public health space, there is a gap between, there's a no-do gap, as we describe it. There's a gap between what we know is the right thing to do or is the effective thing to do versus the thing we actually are doing. And then the quality improvement is the component, the element that helps us to bridge that gap. Right. So because it doesn't take a genius to recognize a performance flaw or performance gap or a weak system. The patients complain all the time. They give feedback. So our system is continuously and always speaking back to us and giving us feedback about what is not working in our design. And in improvement, we understand that every system is perfectly designed to get the results that it gets. And because we have that understanding, there's still that no-do gap, and continuous quality improvement or other improvement methodologies or frameworks give us the opportunity to bridge that gap. So now that we have found the gaps, what do we do to reduce the gap, to leverage opportunities, to improve our system, to correct the anomalies? So we need to set our aims, we need to put in the measures. Remember, again, data-driven process. All right, so these are the elements that we'll look at. And this slide summarizes the three elements that I just spoke to you about. So if we look at this system, if you're able to see this system, this is a system, maybe a country, a hospital, a laboratory diagnostic center that is performing at about 40% of its capacity, right? So that's where they are at. And for whatever reasons, it could be the vision of the leadership, it could be country constraints, it could be resource restrictions, it could be anything that is responsible for this type of performance. But this system, for whatever reason, has embraced this 42%, between 38 and 42% performance level as their zone of performance, and that's their zone of control. They have built in a system to protect that level of performance. But COVID happens, or another monkeypox comes on, and the system drops to about 20%. And then everybody is running from pillar to post. Oh, what's going on? We can't cope with this. People are dying. We're not, our nurses are being burnt out. The workload is crazy. And we know that the system begins to scramble to say, what do we do? How do we get back on our feet? How do we restore sanity to some level, right? And so what helps you in that space of despair is your introduction into a quality improvement program. And we're going to go into the details of how this looks like. But then you get here, and this zone of improvement is where you're trying things out, you're testing things out. Oh, so there is a vaccine that goes against COVID. How do we get this out? We apply improvement science. We apply improvement methodologies. We apply the philosophy behind improvement to apply the tools we know will work and get those to spread and to scale so that we can correct the anomaly in our system. And as you will see in this example we're using, the performance begins to climb in this zone of improvement. So whatever it is we're doing is working. But as we're doing that, we're also collecting data, right, that is being fed back into quality planning, right? So it's an organism, if I can put it that way. It's a life system. And so as we're testing changes and trying things out, we're also collecting data, feeding that back into the quality planning. But we keep on improving. So we introduce different methodologies or models. It can be Lean, it can be Six Sigma, it can be Kaizen, it can be the Toyota production system, it can be the model for improvement where you have the PDSA, whatever model you're used to or that is giving you the result. It can also be a combination, right? A hybrid of some sort of different methodologies that you're familiar with or that you're learning about. And see, this system gets back to 40%. But because of the learning that took place here, that was also fed back into quality planning, there's been an awakening that, wait, perhaps this system can produce better. Perhaps this system can be more effective, more efficient, more productive. And so rather than just get it back from 20% to 40% and then settle in and say, all right, we're back where we're at, we remind ourselves that if COVID or monkeypox or any pandemic or any disaster could get us down from 40 to 20, that means something was missing in our operations, in our system before now. So can we fix those things? And so you continue in your zone of improvement too. With your improvement programs, you continue to do it, and you see the system gets back to 80%, between 80% and 85%. And there it stabilizes and is able to consistently produce the result that it can get. And then you establish a zone of control. Again, you are feeding back into quality planning, even as you're learning to improve your system. And for all it's worth, I know we all like to dream about zero harm and a perfect system, but because it's healthcare, you can ask yourself, why don't we even begin to aim for 100%, right? So it's important that we are able to continue the work of improvement, right, in that space. But why do we need them in the first place? Again, is to provide some form of guide, some scaffolding, a framework or roadmap that you can use to organize the work of improvements, the initiatives or activities or programs you may have at your respective organizations, right? It's also to help you be able to plan based on certain theories, right? So if you're going through the PDSA, you already have that roadmap clearly laid out for you. So you can plan what you would do during the plan phase, the do phase, the study phase, and the act phase. So it's a grounding for you to be able to plan based on theory. It's also able to help empower or equip people in your space to take action, right? If you just sat down without a framework, without a model, things usually fall through the cracks, right? And people just drop the ball because there's no mental model for them to process and guide the work that they are doing. It again helps you to be able to manage resources and in that ensure teamwork. So people know, if I'm using the model for improvement, this is where you come in, this will be your role, this is what you will do. If we're doing Six Sigma, you can say you're not going to come in until we begin to do the measure phase of the make methodology. So it helps you to manage resources, especially human resources, right? And it helps you to also encourage and emphasize iterative learning. So the PDSA ramp, for an example, you're doing several different PDSA cycles back to back to help you understand more. Now, the commonly used QI models in healthcare are not too many, but if you think this number is too many, then well, there are too many. So you have the Six Sigma, you have the Lean Six Sigma, which is a combination of Six Sigma and Lean. You have the Kaizen, you have 5S, which we'll look at in a bit if you've downloaded the mobile app. And then you have the famous model for improvement, and I call it famous because I'm from IHI, right? So, but yeah, so the model for improvement, which is a combination of 3 set of questions and the PDSA plan, do, study, act cycle. And it's all of these are just meant to guide or provide framework, scaffolding for you to transition from random activities to very structured, systematic, methodical approach to the work of improvement. So I'm going to pick up on 5S, basically, because of the game we're going to play. And you can look at this. This reminds me of some visit to some delivery room in Ethiopia, rural Ethiopia, where the maternal mortality rate is high and all of that. And we're trying to apply quality improvement methods using a quality improvement program within those structures. And getting into the delivery room, I remember asking the very passionate and kind midwife who was on duty if she could just pretend that I was a woman in labor who had just come in and was almost at the point of delivery, right? And I asked her, what would you do? Can you just quickly walk me through? And you could see that she was very passionate and she needed to do what she needed to do. And she ran to some other room to get the sphygmomanometer and stethoscope. She checked my blood pressure, and then she had to go to another room, rummage through several different equipment to be able to pick up a fetal stethoscope, right? And then she came and she applied that. And then I asked her, what if I needed to be put on infusion, IV infusion? And she said, oh, yeah, we've got that. And then she ran into another room and she was looking for the IV fluid and then the giving set. And you could, in less than 30 minutes, she was exhausted from trying to provide care for me. And when she was done, I said to her that, thank you so much for taking care of me, but we didn't do so good on time. And I asked her, is there any law or any protocol or guideline that prevents you from having all these things that you naturally would need in an emergency in a space well labeled, right? You don't need money for that. Like you obviously have everything you need, right? But would it be okay if you had them easily accessible to you? Probably create an emergency trolley or cart or something that you could just like reach out and, with very minimal waste of motion and time and all of that, you could get access to everything that you need. And your client would also be better off because you have all that you need to deliver the care that you know how to deliver on time as well. So the 5S Kaizen approach or method basically looks at 5 steps that you take in Kaizen. It's to, first of all, to sort, then to set in order, to shine, and then to standardize and to sustain. Sustain basically about continuity. Now, I know all these things I've said may sound like very big and very confusing, and that's why that game that I asked you to download would go a very long way to explain to you precisely what it is that I'm talking about. So we are going to play that game sometime before the end of this call. But to talk about the benefits, apart from the things I've mentioned in my story about Ethiopia, there will be reduced cost because for some instance, there are times that because of the chaos in your space, you have resources that are not used and you would buy more because you don't even know they're there. Or you're able to provide higher quality care because you're coordinated. You are able to improve your productivity. The same 30 minutes it took this midwife to attend to me, she could have used it to attend to 3 other clients without being tired because she has what she needs per time. And then she herself is going to feel more satisfied because she's not burning out, running from pillar to post. And more importantly, or most importantly, is the fact that it gives you a safer work environment. All right, basically, it's going to walk you through these 5 steps that are highlighted here. And the more you play it, the better you get. But it's going to teach you a very fundamental lesson about what's setting things in order and having a 5S or Kaizen compliant workspace can do for you in your work of improvement. All right, so let's again, so I'm not going to dwell on this because it's something you're either familiar with or you can easily get access to. The model for improvement, we talked about it earlier, the 3 questions, the PDSAs, the multiple PDSA cycles, where you ask yourself, what exactly are we trying to get done here? How would we know that a change is an improvement is the second one. So when you ask yourself, what are we trying to accomplish? You must set an aim. Or what do you want to get done? By when? Where do you want to do it? Who is going to do that? And then how would you know that a change is an improvement is also pointing in the direction of measurements, right? The only way you can know you're losing weight is if you're measuring yourself. The only way you can know your improvement effort is working is if you have indicators. And we usually talk about a family of measures where we talk about the outcome measures, the process measures, and then we have the balancing measures. The outcome measures very related to your aim and actually derives from your aim. When you have an aim, you must also form an outcome indicator that would help you know what is happening with that aim. But that outcome is untouchable. What I mean by that is you can't do anything about the outcome in itself. What you can do something about are the processes that lead to that outcome. So for a very long time, and please don't laugh at me now, for a very long time, I used to do a lot of exercise, going to the gym, carrying the dumbbells, doing my push-ups and going on the treadmill. I could do that for 4 hours every single day. Why? I was trying to lose weight. But guess what? All of these things I just described to you was happening in my dreams, not in real life, right? So I wasn't losing weight in real life because my efforts were happening in a different space altogether, right? But how did I know I wasn't winning? How did I know I wasn't making my aim, right? My goal was because I had measures in place, right? But the moment I started telling myself the diet counts, the time I spend sleeping counts, the time I spend actually exercising in real life counts, then I began to move the needle in the right direction, all right? And so that is also important. The third question is, we know that for improvement to happen, change must come into the picture. But we know that not every change leads to improvement. So the only way we can ascertain that this particular change has led to improvement is if it works. And the only way we're going to know which change is going to lead to improvement is by putting it through the rigor of the PDSA cycle. So that's where the PDSA cycle comes in. Now, let's quickly begin to wrap up here. Now, how do you create an effective quality improvement program? There are certain processes or principles that you have to follow. The first one is what you see on your left. Find your why. That's a book by Simon Sinek. Find your why, the vision for the organization, the vision for the country. Dr. Bishnu mentioned the work is done in Nigeria. If your country has, for an example, a quality strategy, an implementation plan, it means the country has taken the pains to define what quality means to it. The country has taken the pains to prioritize what are the things that are priority to us when we talk about health and when we talk about quality, right? If it's at the organization level, if the organization or hospital or institution has not taken the pain to articulate the why, what's the vision for this hospital? Listening to the elderly gentleman who spoke earlier about the vision of the hospital they've created and has been sustained and is a landmark in India, it's important to see that the vision, even when they are not directly involved in it, is still speaking for itself. So find out the why, either as an organization or as a country. Find out the why for you. What exactly does quality mean? Once that is determined, then you need to determine and prioritize the potential area for improvement. And those can be identified through different means. One, from your vision, what exactly you wanted to achieve. If you're not there, you have an opportunity to move the needle. Two, it can be regulations. It can be the requirements. It can be what the WHO says or what any other organization who regulates your space says about the quality. So that is important. Three, data. You need to use data, and there's no point relying heavily on data that is of poor quality. So you need to collect data, you need to analyze that data, you need to make sure that it's high quality data, you need to make sure your analysis is not biased, right? You need to understand your assumptions around that. Then you need to determine your improvement model. And I put an S in front because I know that across the world, different people have different thoughts about, oh, this is the best model, oh, that is the best model. In my experience, what I've seen is that several different models are more relevant depending on the context. So you need to identify what you would use, what works for you within your system. Do you need to combine Lean and Six Sigma and have Lean Six Sigma? Do you need to do Lean in only a certain aspect? All of these things have to be determined upfront. Then you need to leverage the system of profound knowledge, which I will touch in a bit. You need to communicate your results, transparency, openness, the use of data for decision making. You need to commit to ongoing evaluation, like we say, CAHO is there, and you'll be able to leverage some of the resources that exist within the organization. Then you need to share your story, disseminate your story so that they can be shared learning, accelerated learning. So I mentioned the system of profound knowledge earlier, which is Deming's system of profound knowledge. And basically all it says is that you need 4 things to be able to do the work of improvement in your quality improvement program. You need to have an appreciation of a system, systems thinking. What are you doing in one part of your system that is causing ripple effect, negative ripple effect, or positive ripple effect in other aspects? You need to understand the theory of knowledge. How can you build your knowledge of the system you're working in? You need to understand variation, right? There are some inherent variation in every system that is built into the system. You don't need to react to those inherent variation, especially if they're getting the results. If they're not getting the results, you don't react to that. You go to the source, which is the system design, and you change the system, you change your results invariably. And you need to understand the psychology of change, human behavior. You need to learn what the soft skills are. When you're able to combine this profound system of profound knowledge with any other model for improvement, or improvement models like MFI or Lean Six Sigma, you increase the chances of your quality improvement program succeeding beyond your imagination. So I would want you to just, if I haven't covered anything right now, what are the areas that you think that you would want to maybe double click on and learn more about in the space of quality improvement programs? I would want you to put those in the chat box so that we can, see opportunities for learning and opportunities for improvement as we do this. And also, while you're doing that, please also put in any new thing you think you want us to cover when we come on these calls or these webinars, so that our design is putting you at the center of the work that you're doing. Put in a few references and resources here, starting with the IHI website, and then of course the CAHO website, which you already have, and HRQ, ISQua website, and SQHN, and all of those websites would be huge resources for you. There are a lot of free courses also on the World Bank Group Open Learning Campus, which gives you some foundations of healthcare quality management. So that's where we're going to wrap up today. But I would want you to think about all that you have learned. I think maybe I've spoken very fast, huge information coming your way and all that. However, if you are able to just ask yourself, based on the things that you have learned, what are you going to do different tomorrow? What is going to be different in your work? What's going to be different in your interactions, in the challenges that we're faced with in the public health space? What have you been equipped with today that can help you to have deeper conversations, that can help you to have crucial conversations with people in the positions of power as you begin to change the narrative around what you have in your health space? So that's going to be it from here. I would hand over to my chief to coordinate the question and answer session. Thank you.
Thank you, Emmanuel. It was very informative. Can you go to the chat box?
Thank you, sir.
Yeah. Chandra, how to start the 5S in the very low resources facilities?
All right. Okay, sir. So thank you for that question. So the first thing you need to know is that the 5S is not a function of the resources you have, right? What I mean by that is no matter how much you have, even if it is very little, you need to arrange them in a place and in a way that they serve you. It's about your work environment. So you can have just 5 things when ordinarily you should have 50. Those 5, can they serve you better? Your SFIG, you may need 10 SFIGs, all right, or 5 stethoscope, and you have only 3. Those 3, are they easily accessible? Are they arranged in a way to serve you to be more productive at your work? So it's not so much of the resources. I think it's more of the resourcefulness. So are people, is the workplace, is it safe? Right. So that's the thinking.
What is the difference between 5S in healthcare and industrial 5S?
Great. All right. Great question. So we have to understand, first of all, how that in the quality improvement space, we have borrowed a lot of tools, a lot of thinking, a lot of methodology. For an example, you would remember me mentioning the Toyota production system as a quality improvement program model, right? The FMEA on itself, even the root cause analysis started from aviation, 5 whys from different quarters, right? So the 5S, the basic difference between 5S in healthcare and 5S in other industries would be basically about the environment, the work environment. So when you talk about, when I was talking about the sphygmomanometer, stethoscope, peanut stethoscope, those are the things that we find in the delivery room. In the industries, depending on which industry. So it could be in the hospitality, it could be in the food industry, the tools that you have there, the processes that you have there would speak to how you're going to deploy 5S. So it's the same overarching principle, the same methodology. The application differs because of the differences in the industries that you're using them in. I hope that answers your question.
See another question, Bishnu, that when it comes to analyzing what measures a quality professional needs to choose, when it comes to analyzing what measures a quality professional needs to choose.
Great question. So I would say that if you're a quality improvement professional, you should have skills in your ability to work across the several different types of measures. What do I mean by that? So most of our public health spaces are designed in a way that the focus usually is on outcome measure, because that's what's most important to us. However, at the lower levels in the healthcare system architecture, we know that the processes and understanding of the processes that lead into the outcomes are very important. So I would say that you should have the ability to work with not just the outcome measures, but also the processes, because it is when you are able to move the needle on the processes, then you would be able to influence the outcome measures. So please don't limit yourself only to outcome measures, because they don't tell the whole story. The final thing I will say about that is when you look at outcome measures only, every opportunity you have to improve the system would have come and gone. By the time you're seeing the outcome, all the processes leading to the outcome have come and gone. So as quality improvement professionals, it's important for us to put our eye also on the processes and design those and the interdependencies around those that lead into the outcome measures. Thank you.
You've answered this question, but it's in another. In many suburbs in India, monetary constraints is the key factor to maintain quality. How to implement 5S and quality in the healthcare systems of the countryside setup?
Yeah. So, well, you have I don't think it's only in India that money, right, or resources are constraints, right? Even in Nigeria as well, right? But what we say to people, like I said earlier, part of the benefit of 5S is that it saves cost, because you're able to maintain your equipment, maintain your environment, remove wastes, right, from the things you're meant to do. The example I gave, for instance, was that somebody was trying to attend to me in 30 minutes. And in those 30 minutes, she was all over the place looking for something, walking around. She was passionate. That same space of time could have been used to attend to 3 other clients. While she was attending to me, maybe there's a queue outside. We're losing money. We're raising the patient satisfaction is low. The patient experience is poor. Not because we don't want to work, but because the work environment is not designed to support our productivity. So yes, I think the most important thing is, first of all, start where you are at, right, with what you have. Ensure you put in the removal of waste in that small system that doesn't have all the resources, and then you keep doing your best with what you have. When you have more, you're able to do more, if I can put it that way.
There's another interesting question. What are the potential threats for an effective QIP and how to overcome them?
Okay, great question. The first threat is a lack of vision, right? Because it's a lack of vision on the part of leadership that doesn't allow them to buy in. They should be the one at the forefront. So if leadership doesn't buy into your quality improvement program, it falls flat on its face. That's the first thing. If there is vision, so there are 3 things you need to be able to succeed. The first one is the will, which we call the vision. The second one is ideas, new ideas, innovative ideas. How can we do more with less? The third one is execution. A quality improvement program is not a program if it's only on paper. It's a program when people are about their frontline, the frontline staff has buy-in, they're there doing their work, they are failing on their projects, they're learning from the failure, they're going back to make attempts. So the will or vision, the ideas, the execution. If any of these are missing, you fail. All right. So I will simplify it that way. Those are the three key things.
There's another one. Is there any difference between policies and SOP? If yes, what?
Okay, great. Policies, right, are basically legal documents, if I want to put it that way. So they are documents that provide guidance, right, as to in this hospital or in this country, this is how we do this. In this hospital, this is how we take care of COVID patients. These are the policies. Now, but this standard operating procedures are more specific to, so when you see a patient that is breathless, this is how you manage it. More or less like an algorithm would be an SOP. It gives hands-on instruction. It is more specific, more granular than a policy. Overarching policy may say this is how we take care of highly infectious diseases. But standard operating procedures are more or less like guidelines or guiding documents that teach you step by step what you need to do to get things done. So those are the key differences between what a policy is and what a standard operating procedure document would look like.
There's Aisha Abbas asking you, throw some light on data analysis.
Okay, big question, because there's a whole field called data analytics. But in the space of quality improvement, because we say that quality is data driven, when we talk about data analysis, it's first of all starting from the measures that we selected are important to us. These are the things we want to check: outcomes, processes, balancing measure. When you've received that data, so let me use the example of the Plan, Do, Study, Act cycle as a good example. In the plan phase, we say we want to change this. This is what we want to do. In the do phase, we go out and attempt to do that. But in the plan phase, we tell ourselves, when we do this, we're going to collect data on A, B, C, D, right? When we now do, we document what we're doing. The study phase of the PDSA is for data analysis and reflection. Now you have done what you said you would do. In the plan phase, you predicted that if you did X, Y, Z, if you make vaccines available to people, it would increase the uptake of immunization. That's what you predicted. Now you have done that. But while you were planning that, you also promised yourself you're going to be taking data about the number of vaccines that is made available, the number of home-to-home campaign, the number of vaccinators that are released and paid to do the work. Now, in the study phase, you have collected the data during the do phase. You sit down and say, did our prediction come through? Is there now more uptake? So we have different tools that we can use in data analysis and quality improvement, starting from the basic run chart, where is a time series. We're collecting data of our indicators over time. It is not a before and after like the 5S that I asked you to do. It's a time series where, as the events are unfolding, you're collecting data and you're checking what is going on. So you're able to respond or react depending on what the data tells you. So run charts, control charts, or SHIWA charts are ways. We also have what we call the Pareto principle, or the Pareto chart, that tells you only 20% of your input is responsible for 80% of your result. So when you have a list of 100 things going on in your system, you don't go ahead and begin to tackle all 100. You ask yourself, what is the top 20 that is responsible for this huge result that we're having? So we can go to town on data analysis. But again, like I said, please go to the IHI website, go to the CAHO website, go to the ISQua website, and you would find more than enough resources on how to analyze the data that come your way in the work of quality improvement.
Well, before you wrap up, I think answer the last one. Is there any effective way to engage clinicians in quality improvement programs? I think that's an important
Great question, I must say. Right, so the first most important thing you need to know is look at CAHO for an example. Before CAHO came into the picture, which of us, I'm a physician by training. Nobody taught me anything about quality improvement or patient safety in medical school. And the same goes for our colleagues. Even during residency and all of that, it's how to take care of the patient, you get overworked and all of that. So the fear of the unknown is a first barrier between us and the clinicians. So you must come to that space, not to judge, not to point down and say, you must do this, this is your work, you have to do that. No, it's to first of all understand where they're coming from and engage them from the beginning. Don't design your project and come and tell them what you need them to do. Help them to see the problems. Help them to, you can even look at the data they are generating. They're too busy to even look at the data. They're too busy to see how many wound breaks down. They're too busy to see how many people come into the ER who don't get seen and they return home. They're too busy to see that. When you collect the data in a non-judgmental, non-discriminatory way, engage them to have a dialogue. This is what we are saying. How can we support you? How can we help you? We think we have some ideas of things we can do different. If you tell me as a clinician that what you're bringing into my clinic or my hospital will make me to be less burnt out, I will listen to you. I will listen to you. But if you told me you're not doing enough, you're not helping the matters, patients are not happy, I'll go to hell. Let them, I'm unhappy as well. I'm burnt out, right? So it's the engagement. Engage them early, be transparent, be open, be non-judgmental, be willing to work with them and work with data. Those are the advice I would give to that question. Thank you.
Thank you, Dr. Emmanuel. And some of the take-home points are very important. That why that you mentioned, a lot of times I think so we tell people do this, but why you want to do that, that is not explained. I think that's a very nice thing that you mentioned. And whatever data we get, we must look at it. And because a lot of time we do a lot of activities, what are the outcomes of the activities? That needs to be sort of looked at, analyzed, and that needs to be shared, as you mentioned about getting back to the clinicians. A lot of times we take data which are from the clinicians' workforce, like whether the patients or, and then we don't share it, I think. So that's something we need to share the data properly. And that will go in a big way in quality improvement. I think that some of the things that you mentioned is a huge learning. So with this, I hand over to Vijay.
Thank you, Dr. Bishnu, and must compliment for a fantastic talk by Dr. Emmanuel. Extremely, I would say, motivating, very nice, sir. So thank you so much. I would like to give a certificate of our appreciation to Dr. Emmanuel Ayodeji. You are a great speaker, sir, and we hope to kind of have you in more and more CAHO conferences and sessions. It's a great to have you. So
thank you so much, sir.
I thank all of you for being a part of this program together. And once again, a thank you to Dr. Emmanuel and Dr. Bishnu Panigrahi.
Thank you very much
for sparing your time and being with us. And all my other friends from the governing committee and my friends and all the delegates, thank you so much.
Thank you, sir.